Good afternoon, and thank you for joining us for another edition of Kidney Talks with the GW Ron and Joy Paul Kidney Center, MOTEP, the Minority Tissue and Transplant Education Program, the Pennsylvania Avenue Baptist Church, and of course, BlackDoctor.org. I'm your host today, Suna Halley, and I'm a program manager at the GW Liver and Pancreas Institute for Quality. For today's edition of Kidney Talks, we are focusing on your kidney and genetics. So please get your questions ready. Our presenter for today is show collaborator and trailblazer Dr. Keith Melancon, who is the Chief of Transplantation here at the George Washington University Hospital. Our panelist is none other than Dr. Clive Callender, Professor of Surgery and founder of the Minority Tissue and Transplant Education Program. Without further ado, here is genetics and kidney disease.
Thank you, Suna. Can you guys hear me? Can everybody hear me? This is Dr. Melancon, and I'm happy to be here today. And today I'm going to be tackling something a little bit different because, to be honest, this is a topic that is not as much of an issue in the African American community, but it is an issue when we start talking about kidney disease. And I think it's important to discuss. Firstly, though, I want to say, for me, 2024 is I do have a New Year's resolution. And so I want to state that one of the things in my New Year's resolution, which is number one, drinking a lot more water. So I have my water here. But number two, it's, being grateful. And, one of the things I am grateful for is, of course, my family and my life and what I get to do. I have the best job in the world to be a transplant surgeon. But, I every week I get to, or every other week when I'm here, I get to work with the great Dr. Clive Callender. And I don't think that I've stated enough how grateful I am for that opportunity. He's a great mentor. And I just came back from a big trip up to Chicago, and his name came up so much that I just felt it was important for me to express how grateful I am to be able to work with him, and you guys, how grateful you should be to have such a luminary, on the screen whenever we do this. So first of all, I want to be thankful for that. So anyway, genetics in kidney disease. Much of when we talk to African American audiences in particular, we're talking about this new thing, a relatively new thing, which is ApoL1, and that is a genetic issue, and it's primarily seen in African Americans. It's not the most common genetic disease, and I'm going to get into what the most common genetic disease causing kidney disease. But I wanted to start with ApoL1 because I think it's such an interesting story. Next slide, Suna. I became interested in ApoL1 because, I think all of this stuff started, I know it all started at the NIH because there was some great research going on with some of the groups over at the NIH looking at ApoL1. And the reason why these great, and I mean great scientists at the NIH were involved with this was because for those of you that don't know, HIV-associated nephropathy is a problem. And it's a problem that's, as ironic as it is, it's only seen in African-American patients. And so these researchers at the NIH started looking as to why do you have this problem in the African-American population that you don't see in other populations? And so they started doing some genetic testing, and sure enough, there was an association to this genetic thing that they saw in Black patients with HIV and kidney disease that they didn't see in any other groups, including people that might have HIV and kidney disease. So there was a very, very strong association. And then they started to wonder, well, I wonder if there's an association with ApoL1 and kidney disease and Black patients beyond HIV. And that's where this whole thing goes. Just recently, though, and I know Dr. Callender is going to get a kick out of this. Maybe he knows this, but I found out that there is a therapeutic agent that's going to be coming out that has to do with the treatment of APOL1 disease. And so it to me that opens up a whole uh, different area of conversation, because Dr. Calendar knows for years I've been wondering about this obsession with APOL1 in Black patients. And when I found out that a pharmaceutical company had spent a lot of money to come out with a drug that's gonna be released, I think, next year, all of a sudden a lot of things fell into place. But anyway, going back to this slide, as you can see, I hope that what is obvious when you look at this slide. Oh, by the way, this slide comes from the National Kidney Foundation. So I want people to understand. I don't want to get in trouble. I know recently people have not put footnotes in correctly, and I see I forgot to put a footnote in. And I mean, the young lady at Harvard doesn't have a job anymore. But I got this from the National Kidney Foundation. Did everybody understand that? So this is not my original slide, but it's a great slide. And it's looking at the odds ratio. And look at that. Interferon associated focal segmental sclerosis and HIV associated nephropathy. Look at how high the odds are for having kidney disease if you have APOL1, right? And so it's like off the charts that the combination of APOL1 plus these issues are only seen in patients that are African American. So there is a huge association of APOL1, particularly when you have both copies of the gene. When you're homozygous, meaning you have both copies, you got one copy from your mother, got one copy from your father, and you have HIV and you're Black, you have a very high odds ratio of having kidney disease. Now, this is a real issue, all right? But the problem is to try to take that and look at an entire population. There are other groups that have an issue, like FSGS. So right now, and for those of you that don't know, you can get a panoply of genetic tests. Like you can walk into your kidney doctor's office and say, I would like a genetic test to look at every variant of possible kidney disease. It can be done, and it's very easy. We do it all the time in my office. However, let me tell you, you better make sure your insurance covers it, because these tests can be expensive. And just because they exist does not mean you need to be getting them. There should be a reason that you would want to get a genetic test. But anyway, they can be very easily done. And so if you have lupus, so I would say, if you have other issues, then I think that's where the genetic testing comes into play. So let's say you were recently diagnosed with lupus. All right, most patients that have lupus will not get kidney disease, okay? But there is a subset of people with lupus that will get kidney disease. And that's where you might want to look at a genetic test to see if you also have APOL1, and particularly if you're homozygous. Again, if you have both copies of the gene. Because if you have both copies of the gene and you have lupus, now that is an increased risk. And as you can see here, you have 5 times the rate of kidney disease than the general public. That would be important to know. FSGS, same thing, right? You would want to know, like if you get that, most of the reasons patients get diagnosed with FSGS are not genetic. We worry about the genetic variant, but the most common variant of FSGS is not a genetic disease. But if you do have FSGS, if you were diagnosed, and the way you're normally diagnosed with FSGS is a physical may pick up that you have blood in your urine. We call it microscopic hematuria. So if you have some blood in your urine, a lot of protein, you may get a biopsy, and then the biopsy may say you have FSGS. Okay, so you have FSGS. Well, that's another disease that you then might want to get genetic testing. And that would be a reason for your insurance company to okay it. When you get the genetic testing, and then you have these 2 variants of the APOL1 gene, that's important to know, because as you can see here, that makes your risk of kidney disease 17 times higher. So you may have heard me say in the past, oh, I think there's a lot of hoopla right this ApoL1. ApoL1 can be very important, but it's very important in very specific situations. And I just gave you some of the specific situations. If people have questions at the end, I can go over it. But I just wanted to show you what I'm talking about. Here is the most interesting thing. A lot of people, if you've ever tuned into this show before, most people that have kidney disease because of stuff like diabetes, right? High blood pressure and diabetes. And diabetes is one disease that ApoL1 does not seem to increase your risk of kidney disease with. So, one of the most common variants that causes kidney disease, diabetes, you might believe, oh, well, that's a group of patients when they have ApoL1, both genes, that's going to cause a big increase in kidney. No, actually, we didn't see that. Now, diabetes in and of itself is a risk factor, but the ApoL1 plus the diabetes does not seem to be as big of an issue. So that's why these things need to be caveated out and discussed with individual patients, and you can't just make blanket statements. Next slide. All right, so this is interesting, right? And I think this is where most of the patients end up, which is you have contributing factors. And usually there's a crossover of contributing factors that increase your risk of kidney disease. So genetics is a part of it, but that's just it. It's only a part, right? Most of the reasons why people are going to be susceptible to disease, particularly kidney disease, is because of modifiable factors, right? I've given a talk on genetics versus epigenetics. Epigenetics are modifiable, genetics are genes, right? You are born with certain genes. We as humans, because we love to be able to think that things are inevitable, we love to say, oh, well, my grandmother had this, my mother had this, my aunt had this. No, that's not how it works, right? You can modify all of this by your own behavior, which is why we talk so much about limiting your risk, decreasing your risk by doing things that make you healthy, right? Or healthier. So underlying causes are going to contribute, things like diabetes and obesity. So when you are eating a healthier diet, when you're decreasing your weight, when you're staying active, not having high blood pressure, checking your blood pressure, making sure you stay on top of things, these things make you happy. I mean, make you healthier, happy and healthy. Dr. Dr. Calendar's made a whole career about this idea of being happy and healthy and spiritual. It all goes together. Your spirituality, your mental health, dopamine in your brain, all these things are head in one direction. I saw a patient just in my clinic yesterday. This gentleman lost 100 pounds. And so, my first question is, well, did you have an operation? What enabled you to lose 100 pounds in less than a year? And he basically totally, completely changed his lifestyle. He was drinking, smoking. Although he was brought up in the church, he stopped going to church. And once he changed his lifestyle, once he started going to church, once he stopped drinking, stopped smoking, started exercising, he lost 100 pounds in less than a year. And everything got better. Unfortunately, he already had kidney disease. That's why I was seeing him. But the point is, there's so much that we are in control of as humans. And those are the things that are important. You can't just say that it's in the cards for you to have these problems. Although you do inherit things genetically, but you still have a lot of power over how things that you inherit manifest. I'll just give you one example. Just because you have a gene doesn't mean the gene is turned on. That's what we talk about epigenetics. We call it penetrance, right? So even an autosomal dominant gene, autosomal dominant means that you definitely got that gene from a family member, and that gene can cause a disease. Yes, this happens. It's called autosomal dominant. However, the way it manifests can vary, and that's penetrance. So that's why you could have two people in a family both get the gene that causes a disease, but one person actually exhibits the disease and one person doesn't. So all these factors come into play. Next slide. So now we're going to talk about these inherited kidney diseases. And primarily, I really want to focus on one, because the one that's inherited, that's a big problem we see a lot of, is the one you see there: autosomal dominant polycystic kidney disease. And that particular disease, there are two variants. There is a dominant and there's a recessive form, right? And people that have the dominant form, that's the one where you see so many cases in the family. But like I said, you could ask Dr. Callender, I'm sure he's seen this in his career, where even among affected individuals, meaning they've got the cyst, they've got the gene, all in the same family, one person needs a transplant because they've gone to end stage disease, and the other has cysts, has the disease, has the gene, and lives their entire life, becoming an older person and dying, never needing a transplant. So I just want you to understand, it's not a end all and be all. You get a gene, therefore you're going to get this disease. You're going to need a transplant or go on dialysis. However, this is a big problem. There's a big, huge support group in this country, actually not just in this country, but throughout the world, of patients that have autosomal dominant polycystic kidney disease. And this is true in every ethnic group. But it's interesting because when you trace this gene, and they can do this by looking at variants of the gene, the original mutation of autosomal dominant polycystic kidney disease seems to have come out of Northern Europe. But just because it started there doesn't mean that only Northern Europeans have it, because we've seen it in every single ethnic group, and we see it in African American patients as well. Let me give you the good news about autosomal dominant kidney disease. Although these patients can go on to end-stage renal disease, they actually come in usually in much better shape than a lot of our patients. And that's true about most genetic diseases. And the reason is they have kidney-specific issues, right? Most of the times on this show, I'm talking about systemic issues that lead to kidney disease. So when you have a systemic issue, it's not just affecting the kidneys, it's affecting every organ in the body, every vessel in the body. When you are a diabetic that develops kidney disease, every vessel in your body is diseased because of your diabetes. That's why diabetic patients are more likely to have strokes, more likely to have heart attacks, more likely to have vascular disease. Same things with high blood pressure. When you have high blood pressure, every vessel, every organ in your body is affected by your high blood pressure. When you have autosomal dominant polycystic kidney disease, you have a kidney problem. That's it, right? Sometimes they have cysts on other organs, but usually the cysts, even on the other organs, don't lead to end organ damage. Yes, I have in my career done liver and kidney transplants in patients that have these cysts, but it's rare. Usually this is a kidney problem, and many times these patients will maintain good kidney function all the way to transplant. And if the kidneys are not too big, you can leave them in, and the patients still, even when they get to the point of end stage renal disease, meaning that they're starting dialysis or needing a transplant, they still make a lot of urine. And that's a huge benefit when you do a transplant on a patient, because what you want when you first do a transplant, you want the patients to make a lot of urine. It makes their heart function better, and they are in a much better physical shape, and their long-term outcomes are very good. So autosomal dominant polycystic kidney disease is a gene. We can test for it genetically. Actually, some of my colleagues, when I was at Hopkins, invented this genetic test. It was one of the first genetic tests that we could test for kidney disease. So it's a great test. It's easy to get. We do it. We see it in patients that have it in their family. The most common scenario for us is a person comes forward and they have it and they need a transplant. Well, you're not going to take a kidney from anybody in a family with this unless you can prove that the family member that's trying to donate to them does not have the gene. Because if they have the gene, then you wouldn't want to take a kidney from a young person in that family without genetically testing them. So this is a very common genetic disease to test for. All right, moving on. Next slide. All right, Alport's. But even before I get into Alport's disease, I want a syndrome. I want to say something about FSGS, because I already mentioned, and I just want to mention FSGS because it's a much more of an issue in more patients, and particularly in African American patients. But it's not strictly a genetic disease. Usually it's more of a spontaneous thing. But I just think that a lot more people are going to get diagnosed with FSGS rather than these diseases we are about to cover. But anyway, FSGS can also be tested for, the genetic variant. And that's another disease that can come up with that you can see on a genetic test. So that's why if you have been diagnosed with FSGS, particularly if your kidney function's okay, I do think it's important for you to get genetic testing, not so much for the FSGS because you've already been diagnosed, because it can be diagnosed by pathology, looking at the kidney under a microscope. But it's important for you to find out if you have APOL1 variants. And that's where what I was saying earlier. Those patients, it is imperative for them to find out, because that will definitely increase their chance of end-stage renal disease. The other one that can be spontaneous or genetic, and it's not in my list of diseases here, and why I want to mention, there are two of them. There's membranous glomerulonephropathy and IgA nephropathy. Again, these are not strictly genetic diseases because they can be, but they also can be spontaneous. So if you have them, I do believe it's important to get genetic testing, because you want to find out if you have associated issues, and that would influence how the nephrologist, the kidney doctor, treats you. This is a disease, though, however, Alport's, which, when I was a medical student, I remember this was like one of the first papers I wrote with one of my attendings, because there was a group of patients in Louisiana, of a very large cohort of people that had Alport's disease. And Alport's syndrome is a syndrome where it's an X-linked issue. So usually what is happening is the patients are getting the disease from the X chromosome of the mother, right? And it can go from the mom to the sons, and they will get, but women can have it as well. But the problem is they get hearing problems along with kidney issues, along with some other problems. That's why it's called a syndrome rather than just a kidney disease. It is relatively rare, but it's one example of these genetic issues that go in hand. And really, when you talk about genetic kidney disease, oftentimes we're talking about syndromes, right? Because it's usually an issue with a protein, and that proteins are ubiquitous, right? They're not just in one area. They normally affect numerous organs, and therefore you're not going to get just a kidney problem. You're going to get a kidney problem and a heart problem, now every person with the syndrome doesn't get every manifestation, but these things can go, they can be joined together. Next slide. Yeah, cystinosis. Again, we see this as an issue as well in some patients. Again, very, very rare. That's why I wanted to spend more time talking about polycystic kidney disease and FSGS. These are common things. Something like cystinosis is an exceedingly rare diagnosis. And it has to do with how you break down cysteine, which is, of course, a constituent of DNA. We have a lot of DNA, a lot of protein that have to be broken down in our bodies every day. And if you're not breaking it down, if you're not breaking down these proteins correctly, then you can have a buildup in some of the constituents, and that can lead to problems. So cystinosis is an issue where people get crystals, stones. They can get a lot of stone disease, and it can block the kidneys, and it's really a post-renal issue. and those patients can go on to kidney disease. I've had a few patients in my career that have needed transplants for things like cystinosis, but again, rare disease. Next slide. I think Fabry's disease. Yeah, Fabry's disease is another one, and in these patients, they're just not making enough of one protein because their enzymes are not breaking down another protein correctly. One of the things about the liver and our bodies, again, Dr. Callender often links faith with and science, and one of the things that I often, when I talk about my own personal faith and my practicing of medicine, you realize that the human body is just a wonderfully complex instrument. And if you don't see a wonderful master designer who put this together, I just don't see how people could think that by happenstance, amoebas or bacteria could have become humans. I mean, particularly, these complex, perfect beings. Well, not perfect. We're not perfect, but we are a perfection in so many ways, in the way muscles are made and skin and these enzymes and so on and so forth. Anyway, this is an example how one little issue, one little enzyme in this beautifully complex thing that we are as humans does not function correctly, and it leads to a whole disease state, right? So it just tells you about how wonderfully complex we are and how wonderfully blessed we are to not have any of these issues. Fabry disease, I think I've only done one transplant for this, and now there's actually a medication for patients that are born with Fabry's disease. It's a wonderfully expensive medication. It's exceedingly expensive, but there's actually a treatment, and I think it's on the order of $100,000 a month. The medication, but there is a treatment for Fabry's disease. But maybe we'll get a question from the audience. But it's exceedingly rare. Next slide. Gentleman syndrome, same thing. This is all about the charges. This is another thing. So we talked about enzymes and the breakdown of proteins. Well, every chemical or chemical subtype in the body has charges, these ions. Calcium has positive charges, two of them, and then sodium and all these proteins are charged. They have negative charges, positive charge. And if these ions are not perfectly aligned to neutrality, then you can have an excess in these ions that can cause a malfunction of the proteins inside your various organs. That's what Gentleman syndrome does, and it can go on to kidney disease. This is one I can safely say I have never done a transplant for. So I don't know if Dr. Callender has. He can tell us in the question and answer, but this is one I've honestly I've never seen. The next one I have, but not this one. Next slide. Yeah, tuberous sclerosis complex. Yeah, now this one I have seen. I've definitely done transplant in a few patients that have had tuberous sclerosis. And again, it's like when I started, usually it's a combination. It's not just that they have tuberous sclerosis, but it goes along with high blood pressure or obesity or whatever, and it goes on to end-stage renal disease. In other words, most patients with tuberous sclerosis, I don't think are going to actually get to the point of end-stage renal disease, but I'm just guessing because, like I said, I've seen it so very rarely on the transplant side. What I have seen is that it is a diagnosis in a donor. I'm talking about a deceased donor, and that no one knows if it affects anything because they'll have normal kidney function, but they'll have this diagnosis. And then the question is, do you take those kidneys for transplantation? I must admit that usually I try to avoid those donors because of the risk of kidney disease. But so my point is, most people that I've seen with it really don't have end-stage renal disease. But Next slide. And this is another rare one, nephronophthisis. This is a recessive inherited disorder, which can lead to scarring. I've seen it diagnosed. I remember I've consulted on a couple of patients, but I've never had to transplant someone for it. I've seen people with chronic kidney disease because of it, but I myself have not had to transplant anyone because of this autosomal recessive. Now remember, autosomal recessive means that you need another copy of this gene in order for it to be a problem. It's not going to cause a problem if you just get one copy. So you would need your mother and father to have been a carrier for it to be a problem. It's more like, sickle cell disease. And this is one of the things I wanted to make sure I mentioned, because like I said, it's about how often these things are going to happen. So let's talk about sickle cell disease. Now, sickle cell disease is not something you're going to talk about when you talk about genetic causes of kidney disease, but it really should be, because sickle cell disease, which is a genetic disease, if you have the actual disease, not a carrier, but if you got both of those copies and you have sickle cell disease and you have lots of crisis, which many people with sickle cell have, your chance of getting kidney disease goes way up. And I guarantee you, Dr. Callender can tell us, I bet he's done transplants for people with sickle cell disease. He's probably not done a transplant from everybody with nephronophthosis, but he's done a transplant for people with sickle cell disease, because that's much more common, right? So you can have somebody that has a genetic problem, sickle cell disease, that doesn't cause kidney disease, at baseline, but over time is going to lead to more kidney disease. Same thing with lupus, right? Lupus can be a genetic disease, right? Lupus in and of itself doesn't cause kidney problems, but having lupus over the years leads to a lot more kidney disease. And so when you start talking about genetic problems, it's genetic problems that are going to be more common, that's going to can lead to issues that can lead to things like kidney disease. So next slide. All right, and this is what I was saying. Unlike years ago where getting genetic testing was very difficult, this can be done very easily. But it's just a blood draw, and this can be done in any doctor's office. But like I said, before you go around asking for genetic testing, because people ask for it, but it can be expensive. So it's very important to make sure, before your doctor orders this, that you know what it takes for your insurance to pay for it. And usually there's a caveat of, you need to be looking for some sort of associated finding with something you've already been diagnosed with, in order for the insurance company to cover it. Otherwise, you can get saddled with a bill. Here's the other thing about genetic testing. And there's a lot of bills in front of Congress. I was just up there testifying under Hill just the other day. And this is something we're trying to work on as far as kidney disease goes. But any genetic test you get can be in your file, and it can be seen as a pre-existing problem. So that's the other thing to think about, right? You want to make sure that your insurance company is not going to flag you as having a pre-existing problem because you got a genetic test and it flagged you for some reason. And the reason why I think this is so important, because obviously I do a lot of genetic testing on patients. Yeah, a lot of stuff can come up in a genetic profile, because basically they can look at almost every gene in your body. And just because you have some obscure gene that can lead to some obscure disease doesn't mean it's an issue, right? So from a clinical medical point of view, we are not going to be that concerned about it. But that doesn't mean that some pencil pusher at an insurance company is not going to be concerned about it. So these are the sorts of things that we need to look into as a country. But you should be mindful of this before you subject yourself to any of this testing. Next slide. Okay, all right. I'm ready for questions. Let's go. Let's shoot.
Dr. Melancon, great presentation. So much information given. I have notes here. I'm going to take it back to my family. As the questions are coming in, I just wanted to let you know we have people tuned in from Cameroon, and that even goes back to one of the points that you made with the, genetic testing with the APOL1 being high for the HIV incidence in Africa. So if you're watching from Africa, this is a very pertinent presentation for you to share with your family and friends to make sure that genetic testing is something that you're aware of. So I did want to go back right before the questions start rolling in and give you an opportunity, Dr. Calendar, to answer Dr. Melancon's question. If you have ever transplanted somebody with, is it Gittleman syndrome? And how
Gittleman,
that Gittleman.
Gittleman syndrome. No, I've not, but I've, of course, as you mentioned, transplanted patients with sickle cell disease. Uh, but the other thing I wanted to make a comment about, you said that APL1 is associated with African Americans. And one of the things that I would remind the listeners of is that when we talk about genetic diseases, we sometimes don't quite understand the ramifications. For example, as Dr. Melancon has aptly pointed out, uh, you get APL1 disease, uh, but in Africa, the reason that we are aware of it is because the APOL1 gene prevented sleeping sickness in the Africans. And so that's a wonderful thing for the Africans to prevent sleeping sickness. However, on the downside of it is that it was also associated with what Dr. Melanson has identified as predisposition to some kidney diseases, especially as he pointed out in the HIV population. But I just wanted to remind us that when we do things to the to genes, we don't always know what is going to be the ultimate result of changing the gene pattern in the short run or the long run. And so, just as, for example, we know that sleeping sickness was prevented by APR1, we didn't know until recently, as he pointed out, that APR1 is associated if you have both parts of the gene with kidney disease. The other thing I wanted Dr. Melanson to point out something that he is actually championed for quite a while, and that is what is the importance or unimportance of APL1 in living related donors.
Yeah, thank you, Dr. Calendar. And I'm so happy you brought this up because, as you know, I've been on the soapbox a lot talking about this. And, because of what Dr. Calendar said, which is this association of APOL1 with kidney disease and us learning, I mean, this is like a whole new area of study. What happened in the community, the transplant community, I believe that we put the cart before the horse a little bit. And so what happened is people started doing these genetic testing on African Americans that wanted to donate their kidneys to members of their families or friends. And if they had one copy of the APOL1 gene, they were disqualified from being kidney donors. Well before we showed any correlation or actual data that would state that one copy of the APOL1 gene could cause end-stage renal disease or go on to cause end-stage renal disease. Now, since then, that's been totally debunked, and we know that just having one copy definitely does not lead to any kidney problems. But even having two copies, we now know that this is it's more correlated with kidney disease in certain distinct populations. That's why I wanted to make the point of HIV plus both copies of the APOL1 gene. But I can tell you what our practice is here at my center. If a patient comes in and has both copies of APOL1, so they have two copies, we think that's important. And we definitely discuss it with the patient. But part of our extensive workup is to make sure that that patient does not have any stigmata of early kidney disease. So if the patient does not have high blood pressure, does not have proteinuria, does not have microscopic hematuria, has absolutely normal kidney function, and is at least middle age. So they're going to be over. For us, middle age is 45. So if that person is 45 and older, even if they have two APOL1 copies and they otherwise are okay, we still allow them to donate. Now, we do have them sign a special consent, but really the reason why we have them sign a special consent, because we want them to consent to more thorough follow-up. So, as you know, Dr. Calendar, requires us to follow all donors for 2 years. But for someone like that, we will follow for 3 years. And the reason why we want to follow them is we want to make sure that nothing else happens to them over those 3 years. What I can tell you is, because now it's been over 3 years since I started the program, and not a single person that has both of these genes positive but has no other sequela of kidney disease has developed any issue that makes us worry about their kidney function. But so that's a great question, and you got to remember, well, why do we think it's so important to be aggressive with African American donors? Well, you got to remember, we African Americans, we have the most kidney disease in this country by far, right? We 36% of the people with end-stage renal disease and we only make up 12% of the population. So our people are dying at an inordinate rate with kidney disease. You go to any dialysis center in a major metropolitan city, and it's our people that's sitting on dialysis. So this is not a benign sort of academic question. We are dying when our live donors don't donate. It's important that, if possible, I mean, you never want to increase anybody's risk of disease, but if they're otherwise healthy, you don't want to hold people up from saving the lives of their loved ones. So great question, Dr. Calendar.
I would also at this moment point out that you are doing a great job in terms of live donors. And the most recent UNOS report indicated that for the 10th year in a row, living related donors is decreasing every single year. How is it that your center is not having that kind of decrease?
Yeah, no, great question again, Dr. Calendar. And, I just talked about this. I just gave a talk about this. And I really believe that one of the conversations that we have with donors is we allude to and acknowledge what's going on in the country right now. And this is what I was telling the people that are involved in the organ procurement organizations, which is you got to acknowledge how people feel in this country right now. And what I mean by that is, okay, can you hear us? Oh, I'm sorry.
Yes.
Yeah, African Americans in particular, well, we feel like we are under attack, right? Affirmative action is on the way out. A lot of things like diversity and inclusion programs are under attack. A lot of things that have benefited us seem to be unpopular in this country.
That's
well,
right.
That doesn't happen in a vacuum, right? That affects the way we look at the world, and because of things that have happened in the healthcare industry over the history of this country, we know that oftentimes we are not getting the best healthcare. We're not getting the best access to healthcare. We have been the subject of unscrupulous activities and research throughout the history of this country. So there's a lot of suspicion of the medical community. So, one of the things I do when I talk to people about being a kidney donor is I acknowledge all that. I say, look, I get that you may be suspicious of the healthcare industry for all these various reasons, but at the end of the day, this is about your loved one, right? And if you guys are not going to donate, then the alternative is there. They could wait for a deceased donor, but I'm very factual in giving them the information and telling them how likely their loved one is not to make it to receive a deceased donor. So we have to step up and donate. You, Dr. Calendar, you have made a huge difference in the deceased donor rate in this country among minority donors. I've said this numerous times before, but when I was training, Black people just simply didn't donate after death, and now we do that. We do that at a great rate, better than most other ethnic groups. But live donor continues to be an issue. And when people ask me, because you're right, nationwide it's about 11, 12%, and at my center it's 45%. Why are we doing so much better? I think we're doing so much better because we make a point of educating people about what is going to happen to their recipient. I tell them, there's nothing magical about dialysis. Dialysis is great. It keeps people alive, but it's not going to make your grandmother, your aunt, your brother, your sister live nearly as long as receiving a live donor. And live donation is safe. It's very, very safe. And once you explain this to people, and you explain to them that some of the hang-ups that other programs might concentrate on, like the fact that they might be a little overweight, or maybe have a little high blood pressure, or maybe pre-diabetic, or have metabolic syndrome, that these things can be fixed, right? So we're patient with people. We tell them, look, I do this all the time. I'm like, look, you have a little bit more protein in your urine than you should have, but you're also 30 pounds overweight. Lose some weight and come back and let us retest you. They come back and they're fine, right? And not only are they fine, but we tend to see, not all the time, but we tend to see that those improvements, like losing weight in order to be a donor, they're durable. People tend to keep the weight off. So you got to be patient with people. You have to educate them, and you can't just look at a cookie cutter.
Dr. Melancon, you said something also within your response there that you acknowledging the patient and acknowledging those biases in healthcare is such a huge part of it, and why a lot of, I believe, patients are so hesitant to seek out different providers because they're not validated. But it's such a great thing to hear that that you, Dr. Calendar, at the surgical level, at your level of education, they still acknowledge and validate that yes, there is an issue, but this is what we're doing to address it. So it's just so heartwarming to hear. We have one comment in the audience that focuses on low carb diet being a healthy or keeps your kidneys healthy. And on this show, we've definitely talked about nutrition time and time again. But tying into this presentation for today on genetics and how, yes, there are genes you can inherit, but there's also ways that you can impact that. So is a low carb diet a sure way to keep your kidney healthy, Dr. Calendar or Dr. Melancon?
Well, I would say this, because, people have all these diets that they want to try and whatnot. And I would say first, just kind of a blanket statement that anything that causes you to lose weight, if you're overweight, is good, right? So whatever that diet is, then fine. Okay, so if you lose weight as a result of it, then that's a plus. That's number one. And then before we get to the carb thing, I would say protein, because people make a big deal out of protein in this country. Let me tell you, if you're a typical American, you're getting way more protein than you need. So we don't have a problem with people not getting enough protein in this country, right? People get plenty of protein. So this idea that, I talk to people all the time, well, I want more protein. I'm like, look, you're getting enough protein, right? People don't have a problem with protein in this country. So protein is not an issue. Carbs, yes, carbs can be a problem. But like I said, people tend to get too many calories, period. That's calories from everything. So I say, whatever you do to decrease your calories that helps to decrease your weight is the right thing to do. I wouldn't get so tied up into carbs versus proteins versus whatever. I think that as a general rule, you want to decrease your calories. And then the other thing is, like I got in, I'm not gonna say it's an argument because I don't argue with my mom. My mom is always right. But I was
always.
Yeah, no, she's always right. She's
always.
Yeah. She's probably watching. So you're right, Mom. But I remember I was telling her that, on television now, you can buy these pills that say fruits, and there's another pill that says vegetable. So you can take a pill for fruit and you can take a pill for vegetable. And you know what my whole point was, what's better than taking a pill that says fruit eating fruit. And you know, a pill that says vegetable is eating vegetables.
Yeah.
So I would say eat a lot of fruits and vegetables and lettuce and all that wonderful stuff that God just makes sprout out of the earth. And that's a healthier way to eat.
Dr. Melancon, there's a pill for everything. We
Yeah.
we we've talked about that on this show as well, which is why I love kidney talks. But the reality is there's so much information out there. You can go and WebMD. I mean, there's so many platforms that think that they know the secret and the cure. But if you're not, and I say this almost every show, if you don't have a relationship with a primary care doctor to talk about what is going on with you and your levels and just what your composition is, you cannot listen to everything that's out there on the internet. It will not service you. So very, very true. One practical thing you said today, something that our viewers can go and do directly after viewing this, is do genetic testing. I have a question about how soon is too soon to do a genetic test. Some of these genetic syndromes may be found in children. Do you suggest that parents do genetic testing on children if there is a history of kidney disease in the family? Or do you think that it should be something done later on? Personal testimony, my grandmother had cancer, and that is when they definitely did all the genetic testing to see the mutations and the origin. But outside of that, in my family, I didn't really hear about genetic testing being done as a normal practice. So, what is your feedback on that?
Yeah, I can tell you that because I used to do kidney transplants on kids. So
Mm.
I was at the pediatric program here in Washington, and it's done all the time. So that is already done. I can guarantee you when there's there's a history of a congenital kidney disease in a family. The pediatric nephrologists are all over this, and they actually do a lot more genetic testing at that level than anyone else. So that will get done. That's not a problem. The pediatric nephrologists and the pediatricians get genetic testing more than any other group of physicians, and yes, they are on top of this stuff because some.
We can't hear you. Yeah, we can't hear you. Your sound went out there. Yeah, his sound went out. Nope, no sound. As we're working on Dr. Melanson's sound, Dr. Calendar, your feedback on genetic testing um, as a minor or early childhood, what is your feedback on that?
Well, actually, my recognition is that uh, the commonest causes of kidney disease are not genetic. Hypertension, diabetes, polycystic kidneys, obesity. But on the other hand, if you do not have any of these and you have kidney disease, then it is very appropriate to get genetic testing at any age. Uh, uh, some people forget that we start getting kidney disease because of hypertension at the age of 12. So
Mm.
it's never too young to take blood pressures and to look for hypertension. And then we're having teenage obesity
Mm.
and even younger. So those are the commonest things. But so I'm saying to you that yes, genetic testing is appropriate, but because of the fact that it can be abused, I think that you should first be sure that you don't have the common causes. If you don't have for example, if you have protein in your urine, but you don't have hypertension, you don't have obesity, you're not diabetic, you're not polycystic, and then you really that kind of mandates genetic testing. Often we will do a kidney biopsy if the kidneys are of normal size. But if they aren't of a normal size, then you need to get genetic testing. Recognizing that, yes, there's a place for abuse with genetic testing, and you have to be sure that it's not going to be used against you. And as Dr. Melanson had pointed out, we are in a climate in which we are no longer protected, and the law is now making it uncomfortable to be a minority when we were protected by the Supreme Court and others for a long time. But now it's just the opposite. So
Yeah.
just as he said, we're under attack. So because of that reason, I think that, yeah, get genetic testing if you don't have the common causes of kidney disease. And then do so with protection, with the recognition that the law does protect you from your information being released to insurance companies and others.
All right, we have a question from the audience, and this is from one of our top fans, actually, that says, my brother has been on peritoneal dialysis for 5 years and he has sleep challenges. Is this normal?
Keith, are you? Can we hear you now?
I don't think Dr. Melanson, can we hear you?
Okay, I guess we can't hear. What was the question again?
The audience member says my brother has been on peritoneal dialysis for 5 years and is having sleep challenges. Is this normal?
It is, well, sleep challenges are not normal. Uh, so that in peritoneal dialysis is probably uh, transplantation, of course, is the treatment of choice for kidney disease, end-stage renal disease. But of the dialyses that are done, peritoneal dialysis is probably the best of the choices. And no, it is not common to have insomnia or difficulty sleeping with peritoneal dialysis. So it's a good idea for his nephrologist to look at him and look at other reasons. There may be psychological or other reasons why he has insomnia, but it's something that is important because sleep is important for the brain and for many other issues. In order to be healthy, uh, you need 7 to 9 hours of sleep every night. So if this person has insomnia, this is a reason for them to talk to their doctor specifically about insomnia because peritoneal dialysis is usually not the cause for insomnia.
And for the for the audience member who actually asked this question, our next webinar, ironically, is going to be on brain health in February 9th. We're actually bringing a psychologist to talk about brain health and how things like sleep and the decisions we make are all attributed to the brain. The brain is the catalyst for all the decisions we make. So make sure you tune in February, February 9th from 2 to 3 for our presentation on brain health, which I believe will be a great, you can invite your brother to come and listen to that and also ask some questions.
There are psychiatrists who actually specialize in insomnia.
Right. And they can do sleep studies. So yeah. So that's all the questions we really have from the audience. If you have questions, keep asking them. We can make sure if one part of our show is to address questions every couple months, we go back and answer audience questions. Our last Kidney Talks was actually focused on that. So if you have questions and you'd like us to address them, please put them in the chat. We will make sure to get to them at a later webinar. But we'll go ahead and close out. Dr. Calendar, any last minute takeaways you want to give to the audience?
Yes, I just think that Dr. Melanson gave an excellent presentation on the common genetic diseases, but also his comments about epigenetic have to be underscored. The fact that we can modify the impact of our genes by meditation, by exercise, by adopting a healthy lifestyle. Motep, we talk about love yourself, take care of yourself. Eating less meat, eating more fish, more vegetables and fruit, proper sleep. All of those things help you modify your your genes, and this then would make you healthier. And so, you have the opportunity to modify your health by
Yes.
what you eat and by your adoption of healthy lifestyle.
Yeah, I think that's also my biggest takeaway, Dr. Calendar. I never get tired of hearing about how our behavior impacts our, outcome more than what your mom and dad had. I mean, it's simply said, our behaviors can impact our future for the better or for the worse. And it all starts with one decision each day to do something healthier, to do something better for our bodies. It's not rocket science, and you're hearing it from the smartest people in the world, that it just takes modifying your behaviors and doing one thing better every day. So thank you so much, Dr. Calendar. Thank you, Dr. Melancon, for the amazing presentation. Please, audience members, share this with someone within your community. It really may save their lives. As you know, with kidney disease, if you catch it in the earlier stages, it can be reversed before it becomes end stage renal disease. So you really may save someone's life by sharing this information. So we're going to go ahead and close out the show. Thank you so much for joining us for another edition of Kidney Talks with the GW Ron and Joy Paul Kidney Center, MOTEP, the Minority Tissue and Transplant Education Program, the Pennsylvania Avenue Baptist Church, and of course, none other than blackdoctor.org. We'll see you for our next episode on February 9th, 2024. We will be discussing brain health and how our decisions impact our health. Thank you so much and have a great day.